Thank you. Thank you guys for joining us. We're going to talk about something that we do talk about a lot here at Omega Quant, which is omega-3s and preterm birth. But I'm excited today because this is a big step forward in this process in getting the research to actually be used clinically. So today we're going to talk about new clinical recommendations for DHA and preterm birth. You already said all this. My conflict of interest would be I'm a part owner here at Omega Quant. We do a fatty acid analysis, and we have a patent pending on our prenatal DHA test. The overview for today is we're going to do a quick review of omega-3s in pregnancy. Then we're going to mostly talk about the new clinical practice guidelines from ACOG, the American Academy of Obstetrics and Gynecologists, and then talk about next steps. Learning objectives, why is DHA important? What are these new guidelines saying? Who could benefit from testing and why it matters? So omega-3s in pregnancy is a really big topic, but today we are focused primarily on premature birth, a major issue for pregnant women. Prematurity is the leading cause of neonatal death and deficits in the U.S. Rates of preterm birth are rising across the United States, and you can see from the map, the red states have the worst rates of preterm birth. The blue or the dark blue has the best rates. You want low rates. Our current premature birth rate's about 10% of all births. It's higher in certain populations, specifically African Americans. And we define preterm birth in here and in the rest of the research I'm presenting as birth before 37 weeks gestation. So after 37 weeks to about 42 weeks is kind of your full term month. Early preterm birth is defined as birth before 34 weeks gestation. And the earlier the birth occurs, the more severe the outcomes, the more intensive the treatment has to be to keep that baby alive. The causes for preterm birth are not very specific. We know that general things like stress, being very old or very young, having over or under nutrition, inflammation, all of these contribute to preterm birth, as well as having previous preterm births puts you more at risk for the future, as well as some other more physical differences like cervix length can put you at higher risk. But there isn't a lot of really specific predictive biomarkers or risk factors for preterm birth. So omega-3s, which I'll describe in a moment, have been shown in a large meta-analysis of research to reduce risk of preterm birth. So this is why we are talking about everything we're talking about today. This is a meta-analysis of 70 studies, about 20,000 women, and they found that women who received omega-3s during pregnancy versus those who did not had a reduced rate or risk of preterm birth by 11% and early preterm birth by 42%. So the women on the omega-3 arm had a 42% reduced risk of early preterm birth in these studies. That number, this meta-analysis really kicked off. It's been a long decades of research in this field, but this really kicked off the focus to going from just continuing to do research studies in this field to moving it into clinical practice. So I do need to make sure I clarify what omega-3s are. Omega-3s are polyunsaturated fatty acids. Their first double bond is on the third carbon from the omega end of the molecule. So you can see 1, 2, 3, there's your first double bond. This is ALA and EPA and DHA. They have lots of double bonds. That's the polyunsaturated. So that's the nomenclature. The parent essential fatty acids that we cannot make in our bodies and we have to get from the diet are alpha-linolenic, which is the omega-3, and linoleic acid is the omega-6. So those have to be consumed in order to have these essential fats. But we are focused on EPA and DHA today, eicosapentaenoic acid and docosahexaenoic acid, which are in the omega-3 family that alpha-linoleic acid is in as well. Omega-3s in the body, we can either make them from that parent omega-3 ALA, which we get that from plant-based, which is flax, walnuts, pumpkin seeds. EPA and DHA, however, are not made very efficiently in the body. And fish and seafood are really the only natural source, so that includes fish oil, of EPA and DHA in nature, which is very unique for a nutrient. Usually nutrients kind of are in various types of foods, but EPA and DHA are found in fish and seafood. Interestingly, with regards to pregnancy, our body has a slightly better rate of converting ALA or EPA to DHA in a high estrogen environment, so during pregnancy, which kind of starts to point to the importance of EPA and DHA, especially in pregnancy. So that's what's going on in the body when it comes to and the foods that we need to get omega-3s from. We can measure omega-3s in the body in several ways. At OmegaQuant, our expertise is in measuring red blood cell membrane omega-3 status. So the red blood cell is like a little tissue floating through your body. And so we measure the status of about 3 or 4 months of intake of EPA and DHA through measuring the membrane. Our main test is the omega-3 index. That's EPA and DHA as a percent of red blood cell fatty acids. So we focus on that a lot here, and our target is 8%. But for the prenatal and the pregnancy world, DHA has really been the focus. And so we also have created a prenatal DHA test, doing the same thing, using DHA in the membrane as our marker, but focusing only on DHA. And we used the pregnancy literature to identify a potential target of a good level of DHA in the body as greater than 5%. So that is the difference between the omega-3 index and the prenatal DHA tests. And just also, we are able to measure nutrient status of omega-3s very effectively. But this is also one way of multiple ways of measuring it, like our next nutrition talks is going to go into. Omega-3s, briefly, there is a biological plausibility to why omega-3s are having this effect on preterm birth. And one of the main reasons omega-3s are important in pregnancy is because DHA specifically is a major part of the brain and the eyes. So that's a main reason why omega-3s have been studied in pregnancy for so long. When it comes to preterm birth, the effects of both EPA and DHA are probably related to inflammation potential. Both of those fatty acids have a lower or somewhat anti-inflammatory, and there is a hypothesis that a lot of early initiation of labor that would be for preterm birth is due to an inflammatory process of virus or some kind of stressor. So decreasing that, the inflammatory response may be delaying the birth. So that is the biological rationale in way too short a time. So back to this big meta-analysis that kind of kicked off this big focus on omega-3s and preterm birth. And in that, the author stated, a universal strategy of omega-3 supplementation may be reasonable, although ideally with more knowledge, this would be targeted to women who would benefit the most. So in that study, they found an overall effect of omega-3s, but within the deeper part of the work, they were finding that there are specific women, particularly women who are low in omega-3s, who benefit the most from omega-3s in pregnancy. And so this science is very good. Having the kinds of effect sizes with the amount of data we have on pregnancy is sort of rare. So the researchers feel that the science is well proven and the intervention has been found to be safe. Now, how do we move this into clinical practice? This is just as hard, if not harder, than the research. So first, we have to have a clinical practice guideline that is written by a respected organization and includes clinicians, because it's for clinicians. It can't just be researchers trying to write the whole thing, because researchers are not usually clinicians. After the clinical practice guidelines are written, then we have all the logistical issues. If the diagnostic or the intervention needs to become available to the doctors and their systems, those all have to get figured out. The insurance companies and the hospital systems, are they going to put money and incentivize their doctors to take time to do these things? And then at the end of the day, clinicians have to choose in their practice to incorporate the intervention. So it's still a long road, and we are here. We are at the clinical practice guidelines level. So here we have the ACOG clinical practice guidelines paper. It's first authored by Irene Seaton, I think is how you pronounce it, and Susan Carlson. And it's specifically for the use of omega-3s in reducing preterm and early preterm birth. So I want you to notice lots of authors, half are PhD, half are MD roughly. So we have a really nice mix. And we also have, these are all the affiliations these people have. They're from every continent. It says in the paper, I don't know about Antarctica. I don't know if that counts, but they're from all over the world. They represent multiple associations here on the left-hand side. And so there is a broad and strong support for the conclusions of this paper. And this is really important if we want people across the board to begin taking up these recommendations. So this clinical practice guideline, it was for it's about supplying omega-3s, EPA and DHA in pregnant women to reduce risk for preterm birth and early preterm birth. And the guidelines were developed with support from several medical scientific organizations and is based on the review of strong evidence from randomized controlled clinical trials and the formal consensus process. This is what matters to clinicians. It has to be RCTs, and it has to be doctors that are agreeing that this is good data. So those are critical in this process. And also, how did they do that? How did they bring together that many people and actually get them to all agree on certain on research, essentially? And so a smaller group of people came up with several different statements that really summarize the research and how it would be used clinically. And then they voted on it. So we're going to go through the different statements that made it into the paper. If it had 95% consensus, that was strong consensus. 75 to 95% was just consensus. 50 to 75 is majority approval, and less than 50 is not supported. So the statements in this paper are only strong consensus and consensus. And this process is based on the guideline standards of the association by the scientific medical societies in Germany, and is adopted and used across Europe. So even this process is well known. All right, let's get to the strong consensus statements. First, women of childbearing age should aim to obtain a regular supply of omega-3s from foods, including from fish and oily fish and/or supplements, and looking to get DHA and EPA or just DHA alone. Everyone agreed to this. This is kind of a softball. It's just general nutrition advice. Let's get a little more specific for the general population, including the women in their childbearing years. A regular intake of at least 250 milligrams per day of DHA and EPA, which is already recommended by the European Food Safety Authority. I can't remember exactly. It's a European government entity around food. That's what's desirable. 250 milligrams a day. I want you to remember that. That is a nutritionally accessible dose. You can get that through just eating fish multiple times a week. For pregnant women specifically, additional intake of at least 1 to 200 milligrams a day of DHA is also recommended by EFSA, and that is desirable. So we need to have 250 as our baseline milligrams a day, and then for pregnancy, add 1 to 200 milligrams. So we're at about 450 milligrams a day recommended. Finally, it's important to provide women of childbearing age, pregnant women, and their partners with evidence-based information, preferably both verbally and in writing, on how to achieve an appropriate intake of omega-3s during childbearing age and pregnancy. So they are saying full consensus that doctors should take time in their clinical setting to talk about omega-3s with patients and women and their partners. That's huge because time is probably the most valuable piece, most valuable thing between a doctor and a patient is how much time they have together. And so being able to have full support of this group saying this is worth your time is a major barrier that we're overcoming here. So let's kind of put all these together. There's nothing really new here, which is good because it's going into the clinical world. There is broad appeal for educating people about omega-3s. There's broad appeal for supporting or to encourage people to eat a nutritional amount of omega-3s through fish. What I mean by that is 250 milligrams a day is equivalent to about 2 or 3 servings of fish a week. You add pregnancy in there, you probably have to add another serving a week, or this is why most prenatal DHA supplements are only about 200 milligrams of DHA a day. If you're in the omega-3 world, these are very low levels when we're usually talking about supplementation, but this is baseline nutritional status. And so that's not very controversial. And it agrees with current recommendations, which is also very helpful. They do include the recommendations coming from many big organizations, including the UN and the European Food Safety Authority, EFSA, as well as ISFAL. And so you can see everyone's sort of on the same page for the general public, and for pregnancy, definitely needing at least 200 milligrams a day more because of the increased need. So bringing all those together, they did provide how people would be able to meet these recommendations. This first column is fish with the greatest amount of omega-3 per serving. 100 grams is about 4 ounces. So they're showing that different kinds of fish have different levels of omega-3s. So this is a big part of the education process. It also is important. Tuna is not the most rich in omega-3s, and it's the one that people are often the most worried about because of mercury. And so showing that there are many other options that can give them better omega-3 and are a lower risk mercury-wise. Almost everything is quite low in mercury, actually, especially in the US. So this is saying if you're pregnant, these fish are safe to eat. These fish have these levels of omega-3s. You want to get the higher amounts. So the other reason these all meet strong consensus, I think, is because there's no real change in the clinical process except for maybe taking a little time to talk about omega-3s. So this is kind of like the folic acid conversation in the US, where a doctor will recommend prenatal supplements and say, make sure you get 800 milligrams of folic acid in there. So they might just add the omega-3 right on top of that. The issue with the folic acid is they also have fortified folic acid in flour, so it's in very common foods. So whether or not the doctor's recommendation for the prenatal supplement is making the big difference when it comes to neural tube defects in the folic acid story, it's not clear. So this process of general recommendations by the clinician for supplements may or may not be the most effective strategy. Conclusions with the consensus statements. So these are a little bit less accepted and therefore they're more exciting. So first, they did agree, 85% of these doctors agreed that observational studies in RCTs in pregnant women show that lower intakes of fish and lower blood levels of the omega-3s, DHA and EPA are associated with significantly increased risk of preterm birth and early preterm birth. So they're agreeing that this is a real live option for a risk factor for preterm birth, which is very exciting and very important. And almost 90% of the votes agreed that intakes of up to 1,000 milligrams of DHA and EPA, or just DHA alone, does not raise safety concerns in the general population or in pregnant women. That's really important. This is a level 4 times higher than the baseline intake. We are out. This is very hard to get just through fish. So we're talking supplementation now. 90% agreed that pregnant women with a low DHA intake and low DHA blood levels are at increased risk of preterm birth and early preterm birth, and they should receive a regular supply of approximately 600 to 1,000 milligrams of DHA and EPA or DHA alone, according to the results of the RCTs demonstrating significant preterm birth reduction. This is the whole shebang. This is the new clinical protocol to identify women low intake of omega-3s or low blood status and treat with a dose that is higher than what you could get in the diet alone. And that is the most exciting and potentially impactful consensus statement. And it's already at 90%, even though it is, it's definitely kind of a hot off the presses type of clinical practice. The additional supply of omega-3s should begin in the second trimester, and at least by the second trimester and no later than 20 weeks. I do not believe this means you shouldn't be taking omega-3s before then, if you already know, but it's still effective to reduce preterm birth, starting the supplementation in the beginning middle of pregnancy, which is fantastic. The high dose supplementation should continue as long as there is a risk of preterm birth. So take the supplementation until 37 weeks gestation. And then there is probably a good practice would be to stop supplementing if you want to not delay labor until 41 weeks or something. I think that also is an indication that the omega-3s are actually doing what we think and see that they are doing in delaying labor. Identifying women at increased risk for preterm and early preterm birth due to a low DHA intake or status is achievable by screening with a few questions of a dietary questionnaire on their intake of foods rich in EPA and DHA and use of omega-3s. So that's also fairly rare, and we'll talk about that more in a minute. The DHA measurement of a blood lipid component is an additional option to identify women with low status. However, further standardization of lab methods and appropriate cutoffs are needed. So this is also what we'll talk about later, the 2 ways we can identify who would benefit the most from these supplementation regimens. It's either the dietary intake data right now or the blood measurements, and both have pros and cons. Okay. So those are all the statements that this group came together. To quickly recap, they are saying women with low omega-3s are at higher risk of preterm birth. Therefore, it's a risk factor. This is a big deal if this could become accepted. It's a risk factor that also relates directly to an intervention, which is great, but just having a risk factor is really important. Over half of preterm births are for no known reason, no risk factors, no indication. And so we need a lot of help in this area to help with that. The other thing that's important here is the higher dose is needed to have an effect on preterm birth rates. So we can't just use the nutritional 250 a day, 500 milligram a day type of advice for everybody and expect to see a result. The research studies are showing if women have low status, they have to have a high dose to have the effect on early preterm birth. So we are out of the diet realm and we're into more targeted supplementation. And like I mentioned, making sure we get started by at least 20 weeks at the latest and go until 37 weeks can really, that's really the sweet spot. But I would say taking fish oil the whole time is probably the best option prior to getting pregnant. Why is it important to identify women who are low? The research has shown that the efficacy of the treatment is determined by the baseline omega-3 status. If you don't know the status at baseline of omega-3s, you may not see a result. You may not actually make an impact because you haven't considered baseline status. So important. The treatment's beyond nutrition, has to be very, it's not easy to get 1,000 milligrams of DHA a day. And having this diagnostic and treatment together, hopefully will motivate the patient and the clinician to actually follow through. This is a chance to do something to actually reduce risk of preterm birth. We don't have much else that they could actually do. And so this is the only real research I'm going to show, but just to show you how important knowing the status is. This is from the ADORE study that Susan Carlson ran. She's one of the main authors on the study. And it's part of why identifying the low intake women is so important. So they had women come in, their DHA status was measured at baseline in the blood. It was about 5% on our prenatal DHA. It's been converted to our levels, so very close to that 5% cutoff. Now, women who came in with less than a 5% prenatal DHA at baseline, they got the lowest amount of fish oil, or the 200 milligrams of DHA a day. They had the highest rates of early preterm birth, so 4%. Those same women with low DHA status got a high dose of DHA. That rate was cut in half to 2%. That is an effective treatment, and this is the data showing us that we need to be able to find the women to intervene on. The other group of women had DHA greater than about 5% at baseline, and for them it didn't matter what dose they got. They had lower rates of preterm birth and early preterm birth across the board, and we didn't need to provide 1,000 milligrams a day to that group. They were okay with the current general recommendation. So this, I think, really encompasses those two sides to this, the nutritional and the treatment. The ways that we can identify women with low omega-3 intake or status is a logistical challenge, and there are two ways we're trying to do it. First, the diet survey. So right now, Dr. Susan Carlson does a research at KU Medical Center in Kansas, and they are really working on implementation and working through all the obstacles it requires, or all the obstacles that actually clinically practicing this entails. So they've decided to go with a system where they're using a 7-question survey that they used in their studies with patients. So it's now a survey that their OB patients can take in their electronic medical record using REDCap. It's 7 questions, and they have good evidence that if they come out as estimating less than 150 milligrams of EPA and DHA a day, then they are low and they need that high dose. Omega-3s are unique because they are really only found naturally in fish and fish oil or fish oil type capsules. So it's sort of easier to identify intakes of omega-3s compared to other nutrients. And they also have recommendations of what supplements and how much to get in the results. And while this is a great way to get this started and get the interest going with the clinicians and the patients, when I've spoken to them, and this was maybe a year ago, so this might be older news, but initially they were having trouble getting all their women to actually use the questionnaire. So really only a small proportion of the women did the questionnaire. The clinicians weren't necessarily using the questionnaire results with their patients or following up with them. And we know in general, dietary intake is not the most reliable method to identify nutrition status. So those are not all that surprising. It sounds like real life. Hopefully it's gotten a little better as intake or as they've had more time with it. But while it's cheap, to do a questionnaire, there are issues with its actual impact, it seems like. When we talk about blood testing, the pros of blood testing is that it could be incorporated into a normal lab flow. It isn't yet, but that's the idea. And pretty much everyone gets labs. If you're coming in for a prenatal visit, you're going to get blood drawn for a number of things. So you won't miss anybody. It's a diagnostic. It doesn't rely on the patient to go through and actually do a quiz on their EMR and have access to that and think of that. And having a number that's in the blood might be more motivating to both a clinician and a patient than a dietary recall result. But the cons are that currently clinical labs are not set up to test fatty acids, and the machines we use gas chromatography. These are not standard machines in clinical practice by any means. It's a specialized type of analysis. So that's a logistical hurdle that we're going to have to figure out. Not only that, how we report the omega-3 status is not been standardized. So this is what they were alluding to when they said the blood testing has to be standardized before it's actually useful. So right now, we measure red blood cell DHA. We offer that. It's called the prenatal DHA test. Our target set at 5%. The Carlson group at KU, they did red blood cell. They did a little bit more of an extract. They just measured the phospholipids, even though red blood cells are almost all phospholipid. Just method differences, their target is greater than 6%, but because of the method difference, it's actually equivalent to our 5%, which was exciting when we figured that out. And the other main group in Australia, they were using whole blood and or plasma and measuring total omega-3s, which is ALA, DHA, DPA, and EPA. And so their number is completely different. They're looking at getting people either greater than 4.1%, or all of these you could look at the other way. If they're less than these numbers, you would treat. So this is an issue. The lab science community, if we want testing to be available and an option, we all kind of have to row in the same direction. And the other issue is getting red blood cells can be an issue versus plasma. Almost everything is measured in plasma. And so that is the issue with blood testing. Here are the future research statements by this consensus group, and it has everything to do with what I just said. Essentially, here they're talking about evaluating the dietary screener with more people in more ways using digital tools and really validating that more. And then the future research is we need to get the lab methods all singing the same song, having the same cutoffs, using the same blood types. And with respect to the future research for treatment, they wanted to know how using the high dose supplementation would affect women who have high risk for preterm birth for other reasons beyond just having low DHA status. So the history of preterm birth or reduced cervical length. See how effective the DHA could be in other settings. They also mentioned that it's not 100% clear in the research what preterm births were spontaneous versus physician-induced in all of the studies, and that's really important. Sometimes preterm birth is absolutely necessary, and the physician will induce it, especially in cases of like preeclampsia. And so that's an important piece too. And in the future and now, trying to make sure this is not only something that's implemented in the higher income countries, but can be available to low and middle income countries as well. And so now for the clinician, we have a really great start. They're able to put in this one little box kind of everything I just went over. And they have kind of two levels. They have the nutritional advice that everybody could do. And then they have the really exciting and interesting intervention for people who don't meet those nutritional intakes. So this is a great start. And now we have a clinical practice guideline to get started with. We still have a lot to work to do on the logistics. And once logistics are sorted, we then have insurance companies and hospital systems to deal with, but at least we've started. And so these are some of the issues down the road. Insurance, testing currently isn't covered because it isn't really known. There is not a specific CPT code for a pregnancy DHA test. The hospitals, the testing would have to get incorporated into the EMR, incorporated into their menu and billing. The dietary questionnaire isn't standardized either, and the clinicians have to want to use it. And the labs need to get the fatty acid testing sorted out and get the reporting standardized. And all of this is now more of a political will issue than a scientific issue. Because just because the science says so doesn't mean things happen in the clinical world. All this other stuff has to be in place as well. So that's why I'm so excited about the clinical practice guideline, because it is the first step on that political process of convincing people that this is important and we need to invest in it. And reducing preterm birth is really important. The longer the baby is in the womb toward full term, the more developed they are, and the more and usually statistically fewer cognitive issues and other issues with development. But it's the omega-3s. If we are able to increase omega-3 intake kind of for the immediate purpose of reducing preterm birth, we're also going to get all the other benefits of omega-3s for both mom and baby. And that's probably most obvious when it comes to cognitive development of the child. So this is the first 1,000 days. Throughout the first 1,000 days, it has an incredibly impactful, it's incredibly impactful throughout the whole lifespan, which is both exciting and terrifying. And so having more omega-3s in pregnancy during that time, during that very important brain development time, and for the first 2 years after that, could have a big impact on the cognitive health of our future. So it's not just preterm birth. There's a lot of other benefits for omega-3s as well. Final thoughts on this topic from me. The strong consensus is the nutritional recommendations. So it's nice to see, but, and also if these were followed by the general public, they would have a positive impact on preterm birth rates, because those intakes get you to about 5%. It gets you to that level of lower risk. However, the consensus statements, the ones with a little bit less consensus, are the exciting ones. They're the breakthrough protocols. They're the ones that can help treat in the moment someone who might be at risk, higher risk for preterm birth. And for a clinician to use omega-3 levels for diagnosis or for treatment, all of the pieces of the process have to be in place, and all of that will require more consensus building and more political will. All right, so that is the ACOG recommendation paper. Very excited about it, ready to take questions. Before we get there, we have, if you have clinical questions, we have Kelly, who's an RD with us that you can write to. And also we have Tavis if you have questions for sales and account questions. And our next talk is about omega-3 tests and the differences between them. So that should be really practical and helpful, because it's confusing, and it shouldn't be so confusing. And we do a lot of education at OmegaQuant, and now we have a place where they all live, and you can get some of these talks on demand, some free, some paid for. We have just all kinds of stuff available.